Welcome to Practical Clinical Applications of Trauma-Informed Care, part 2 of a 2-part online module series. From 2020 to 2021, while affiliated with Ascension Health Our Lady of Lourdes in Binghamton, New York, and receiving support from Care Compass Network, I served as principal investigator of 2 IRB-approved clinical studies, which made the Lourdes Center for Family Health at 303 Main Street in Binghamton, New York, the first site in the regional system to implement a universal trauma-informed care training for all staff and physicians, and the first site to implement universal screening of adult patients for adverse childhood experiences. The study showed statistically significant increases in the healthcare team's trauma-informed care workforce development, awareness, education, and readiness to implement trauma-informed care, an increase in resilience, as well as patients' measured rapport with the physician and clinic staff team. After the conclusion of my studies, I allowed Ascension to share my modules with their 3,000 patient-facing providers and staff. It is our hope that our region continues in the footsteps of the leading medical innovators and institutions in the United States to make high-caliber trauma-informed care training such as this part of permanent workplace culture. As of 2019, the majority of people currently living in the United States have experienced at least one kind of adverse childhood experience, and that includes both the patients who come to institutions for care and the providers and staff members working at the institutions who help care for them. Trauma-informed care seeks to be an antidote for the ill effects of adverse childhood experiences. We are going to hear a video from the California Surgeon General, Dr. Nadine Burke-Harris, about epigenetics and how childhood trauma affects health across a lifetime.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, Why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
On this slide and subsequent slides, we will be referring to healthcare professionals, which we intend to describe not only doctors and advanced practice providers, but any patient-facing member of the healthcare team. Trauma-informed care boils down to two components: resilience plus empathy. Resilience practiced by the healthcare professional daily to respond to the challenges of life, also known as bouncing back. And empathy is practiced by the healthcare professional daily to understand and share the feelings of others. As we saw in part 1 of this 2-part online module series, Championing Trauma-Informed Care, resilience can mean different things to different people, but usually it is a combination of 4 categories of events and exercises that relate to taking care of your body and brain, setting and keeping boundaries, practicing gratitude, and having a strong social support system. In the previous slide, we learned that frequent mindfulness practice can be part of one's comprehensive plan to increase one's level of resilience. However, it is fascinating to know that there have been scientific studies that show that mindfulness, particularly a specific style of mindfulness, can also increase one's power to empathize. Dr. Tanya Singer, PhD, director at the Max Planck Institute for Human Cognitive and Brain Sciences in Germany, conducted a large-scale clinical study and found that affect mindfulness, which includes the subtypes of gratitude meditation, loving kindness meditation, and dyadic meditation, causes significant thickening in the brain's cortical regions from the right insula to the temporal pole. These regions are linked with the brain's power of empathy, compassion, and emotion regulation. Now, we are going to go through a guided affect mindfulness meditation by Dr. Emma Sapala from UC Berkeley.
Let's begin the loving kindness meditation. Close your eyes. Sit comfortably with your feet flat on the floor and your spine straight. Relax your whole body. Keep your eyes closed throughout the whole meditation and bring your awareness inward. Without straining or concentrating, just relax and gently follow the instructions. Take a deep breath in and breathe out. Keeping your eyes closed, think of a person close to you who loves you very much. It could be someone from the past or the present, someone still in life or who has passed. It could be a spiritual teacher or guide. Imagine that person standing on your right side, sending you their love. That person is sending you wishes for your safety, for your well-being, and happiness. Feel the warm wishes and love coming from that person towards you. Now bring to mind the same person or another person who cherishes you deeply. Imagine that person standing on your left side, sending you wishes for your wellness, for your health and happiness. Feel the kindness and warmth coming to you from that person. Now imagine that you are surrounded on all sides by all the people who love you and have loved you. Picture all of your friends and loved ones surrounding you. They are all sending you wishes for your happiness, well-being, and health. Bask in the warm wishes and love coming from all sides. You are filled and overflowing with warmth and love. Now bring your awareness back to the person standing on your right side. Begin to send the love that you feel back to that person. You and this person are similar. Just like you, this person wishes to be happy. Send all your love and warm wishes to that person. Repeat the following phrases silently. May you live with ease. May you be happy. May you be free from pain. May you live with ease. May you be happy. May you be free from pain. May you live with ease. May you be happy. May you be free from pain. Now focus your awareness on the person standing on your left side. Begin to direct the love within you to that person. Send all your love and warmth to that person. That person and you are alike. Just like you, that person wishes to have a good life. Repeat the following phrases silently. Just as I wish to, may you be safe. May you be healthy. May you leave with ease and happiness. Just as I wish to, may you be safe. May you be healthy. May you live with ease and happiness. Just as I wish to. May you be safe. May you be healthy. May you live with ease and happiness. Now picture another person that you love, perhaps a relative or a friend. This person, like you, wishes to have a happy life. Send warm wishes to that person. Repeat the following phrases silently. May your life be filled with happiness, health, and well-being. May your life be filled with happiness, health, and well-being. May your life be filled with happiness, health, and well-being. Now think of an acquaintance, someone you don't know very well, and towards whom you do not have any particular feeling. You and this person are alike in your wish to have a good life. Send all your wishes for well-being to that person, repeating the following phrases silently. Just as I wish to, may you also live with ease and happiness. Just as I wish to, may you also live with ease and happiness. Just as I wish to, may you also live with ease and happiness. Now bring to mind another acquaintance toward whom you feel neutral. It could be a neighbor, or colleague, or someone else that you see around but do not know very well. Send all your good wishes to that person, repeating the following phrases silently. May you be happy. May you be healthy. May you be free from all pain. May you be happy. May you be healthy. May you be free from all pain. May you be happy. May you be healthy. May you be free from all pain. Now expand your awareness and picture the whole globe in front of you as a little ball. Send warm wishes to all living beings on the globe who, like you, want to be happy. Repeating, just as I wish to, may you live with ease, happiness, and good health. Just as I wish to, may you live with ease, happiness, and good health. Just as I wish to, may you live with ease, happiness, and good health. Take a deep breath in and breathe out. And another deep breath in and let it go. Notice the state of your mind and how you feel after this meditation. And when you're ready, you may open your eyes.
It is important to realize that environmental triggers can both form epigenetic vulnerabilities in childhood, but also exacerbate pre-existing epigenetic vulnerabilities throughout a lifetime. Adverse childhood experiences, known as the acronym ACEs, are 10 specific traumas experienced before age 18, which cause lifetime epigenetic vulnerabilities. This should be contrasted with social determinants of health, SDOH, which are all the environmental conditions, both animate and inanimate, that may set the stage for traumas to occur. Social determinants of health help form the traumas, which in turn form the epigenetic vulnerabilities in childhood. And social determinants of health may also exacerbate, also known as trigger, pre-existing epigenetic vulnerabilities throughout a lifetime. However, the terms ACEs and SDOH are not interchangeable, and these two phenomena should be considered as separate entities. As we saw in part 1 of this 2-part online module series, Championing Trauma-Informed Care, The University of Buffalo identified 5 pillars of trauma-informed care, which are safety, choice, collaboration, trustworthiness, and empowerment. These are feelings that the recipient of trauma-informed care should experience after interaction with the healthcare worker, no matter whether that recipient is a patient or a colleague of the healthcare worker. The opposite of these 5 feelings are the feelings of abuse. And it is imperative that the healthcare professional always conduct themselves with patients and colleagues in a way such that everyone that they interact with always experience these 5 positive pillars. The healthcare professional who elicits the 5 pillars of trauma-informed care should make sure that their speech and their actions reflect the goal of eliciting the 5 pillars. One way you can do this with patients is by actually using the words safety, choice, collaboration, trust, and empowerment to express your genuine trauma-informed care for the recipient. And it must be stressed that merely saying positive statements while internally thinking something quite different are not enough and will be discoverable by the patient. The healthcare professional must truly be speaking genuinely from their heart, and their actions and entire conduct all align in unison will achieve the goal of healing. Here are some examples where we've done just that. Here are examples of what not to say in the goal of pursuing trauma-informed medical practice. As we discussed, the opposite feelings of the 5 pillars of trauma-informed care are the feelings of abuse. These specific examples were gleaned from real life, and we encourage you not to talk like this to your colleagues or to patients. Let's analyze in a deeper dive daily practice and ways we mindlessly re-traumatize patients during medical encounters and thus exacerbate the biologic phenomena which contribute to overall ill health. It cannot be stressed enough that trauma-informed care must be practiced universally with all patients, as studies show that not only do the majority of adult Americans have an ACE score, but that looking for outward signs of patient re-traumatization is a highly unreliable method to gauge if re-traumatization is actually occurring. You must operate with the resolve that non-trauma-informed body language and speech is unacceptable in any medical setting and unbecoming of a healthcare professional. When you become mindful of this in your professional life, you will see transformation outside the workplace as well, into all areas in which one contributes. To start, it's important to respect a patient's personal space continuously during encounters. Do not block either physically or visually the exit door of the examination room, as this can be potentially triggering for a patient. The healthcare professional, upon entering the room, should sit down to be no higher than eye level with the patient. Continuing on the theme of respecting a patient's personal space, when assessing a patient, do not stand directly in front of the patient and block their line of vision. The patient should always have an unobscured view of the door. Do not needlessly touch parts of the patient's body which are not being examined. Both problems of the first picture are easily avoided when the assessor stands to the side of the patient. On this slide, again, we would like to reiterate the importance of not needlessly touching parts of the patient's body which are not being examined. A patient in a medical encounter gives their consent to be medically examined. They do not give consent to be touched for purposes other than medical examination. The same is true regarding respecting a patient's personal belongings. I will give you an example from real life in the non-acute outpatient setting. A healthcare professional wanted to sit down to be at eye level with the patient upon entering the room. However, in doing so, proceeded to forcibly lift the patient's open purse that had been sitting next to them, with the patient's personal and potentially sensitive items in full view and also at risk for falling out of the purse. up onto the floor so that the healthcare professional could sit in the chair. Not once did the healthcare professional ask consent to do so, and this seemingly innocuous action in the mind of the healthcare professional was actually a very triggering situation for that patient, and the patient never returned to that healthcare professional. Helping to set the agenda with the patient educates patients beforehand on what to expect during the entire encounter. Every member of the healthcare team can help to set the agenda. It helps to relieve patient anxiety. It helps to avoid confusing patients. It helps to spare patients from the embarrassment of admitting that they may be confused. It helps to respect the patient as an integral member of the patient's healthcare team. It helps to educate the patient on what they may expect at other medical offices. It helps to educate, relieve anxiety, spare from embarrassment, and include, if the patient has consented, the patient's guests and or family as integral members of the patient's healthcare team. Setting the agenda and exclusively using appropriate trauma-informed language includes identifying yourself by verbally stating your title, whether you're an MOA, a nurse, a physician, advanced practice provider, etc. Briefly explaining why the need for the test, intervention, or policy, and always substituting the for your when describing patient body parts, bodily specimens, or articles of patient clothing, and continuing to educate patients on what to expect at every step of the encounter. You should use simple clinical language. Inform the patient that a chaperone will always be provided upon request and should be mandatory during every sensitive exam. Ask the patient with which chaperone gender or genders they would be most comfortable. Patients with ACE scores may appear nervous or distracted during visits, have elevated heart rates, non-adhere to treatments, cancel or miss appointments, or have vague generalized symptoms. As previously discussed in the previous slides, it is important that we as healthcare professionals respect patients' unspoken concerns during assessments. Be equal to patient's eye level. Do not stand over a sitting patient. Throughout an encounter, the healthcare professional should continue to check nonverbal behavior that a patient is exhibiting. But remember that not all patients who are being triggered or have a history of trauma emanate readily observable nonverbal behavior. It's important that what we do during each encounter is as standardized as possible. It will bring a level of comfort to the patient when they see a familiar routine. For instance, the healthcare professional knocks on the door, enters, greets the patient by name, introduces oneself with title, washes their hands or uses the hand sanitizing foam, sits down, starts opening up their computer to type into the EMR and explains to the patient that they are listening to what the patient has to say, but unfortunately they do have to type into the EMR, and receiving consent for physical examination. Also, making it standard includes treating all patients with the same 5 pillars of trauma-informed care during each encounter and not displaying biases. Ultimately, ideally, eradicating all biases against patients who may be different from you or have complex needs. Lastly, it is important that during the encounter, the healthcare professional identifies concerns that a patient has by actually asking if the patient is comfortable regarding any and all aspects of the patient discussion. Again, it is important to realize that relying on nonverbal behavior, body language from the patient is not a reliable way to identify who has a history of trauma or who is being actively triggered. This is why it is crucial to universally conduct each encounter with each patient in a trauma-informed care manner. Patients with high ACE scores may have a harder time with emotional regulation. This can translate as yelling, swearing, arguing, or becoming impatient with clinicians and staff. Let's hear from Dr. Harris what happens to the traumatized brain that can lead to outbursts of aggression, volatility, and irregular behavior sometimes.
Let's have a look at what's going on inside the brain when people have been traumatized that leads to these exaggerated fight or flight responses, that leads to these kind of outbursts of anger and aggression, or these kind of exaggerated startle responses and so forth. And I'm going to introduce you to 4 metaphors which I hope will be helpful to you in remembering what goes on here. So I'm going to talk about the data analyst, the emergency alarm, a mission control, and the security guard. So let's talk first of all about the data analyst. This is the thalamus, an important part of the emotional brain. The thalamus gathers data together from the external world and the internal world. So all the data that's coming to you through your 5 senses, what you can see and hear and touch and taste and smell, all converges on the thalamus. All the stuff that's coming from your internal world, your proprioception about where your body is, the state of your muscles, what's going on in your digestive system, your heart rate, your respiratory rate. So all of this info about the internal world and the external world converges in the thalamus, which is like a sort of data analyst, puts it all together. And the data analyst sends that information off in 2 different directions. There's a slower pathway, which is often referred to as the high road, and there's a faster pathway, which is often referred to as the low road. Now, let's have a look at the fast low road pathway. The data analyst sends this information as fast as possible to the emergency alarm. This is the amygdala. The amygdala is like the emergency alarm of your brain. If it detects a kind of threat, whether it's a real threat or whether it's a perceived threat, it fires off. Woo, 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 danger, 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 danger. And it has to do that job well. If you've got a defective emergency alarm that doesn't go off at the slightest hint of a threat, then you're not going to live very long. If we look back in evolutionary times to caveman days, if there was a caveman whose amygdala did not fire off at the slightest sign of a threat, then he got eaten pretty quickly. So the thalamus collates this data, the data analyst sends it at lightning speed to the amygdala, the emergency alarm of your brain, which fires off and sends a message down to your security guard. Your security guard is your sympathetic nervous system. The security guard needs to either take cover or shoot. What's most important? Do I shoot, the kind of fight stuff, or do I take cover? Now, that's the fast road. That's often called the low road because it's using the lower parts of the brain. If we come back to Dan Siegel's hand model of the brain, the high road involves the parts of the brain that are closest to or part of the cerebral cortex. The low road involves the kind of lower parts of the brain neuroanatomically. And so your amygdala is right here in your emotional brain, and it's sending that information. The alarm's gone off. It's sending that information down to the security guard, the kind of fight or flight sympathetic response, the lower part of your brain. Now, that's much, much faster than the high road, that basically the thalamus sends this information at the same time to what we might call mission control. So mission control is the medial prefrontal cortex, this bit of your brain that's right up front, just above your eyes. This is like mission control. It gathers all the data together and it makes an informed response. You become aware of what's happening. You can tap into different parts of your cerebral cortex and make an informed decision about whether or not this is a real, genuine threat that you need to take action on, or whether it was a perceived threat and you're actually okay. So that's quite a few microseconds slower than the low road fast response. The amygdala, or the emergency alarm, also sends information to mission control. And again, though, that's slower than the immediate response that's gone to the security guard. And so what's happening in the traumatized brain is that the data analyst is continually feeding inaccurate data to the overactive emergency alarm, which is firing off again and again and telling the security guard over and over to take cover or shoot. And so we're getting this kind of sympathetic hyperarousal, this kind of anger, irritability, or fear and startle and withdrawal and retreat over and over again. throughout the course, I'll be referring to these metaphors and these parts of the brain, and really don't worry too much if it seems too much or you can't remember all these bits and pieces. You know, it's useful knowledge to have, and sometimes it's useful to share this with your clients as part of psychoeducation, but it's not something that you have to kind of really struggle with if you're finding it difficult to store this in your long-term memory. And keep in mind that a lot of what we're doing throughout this course is working with the medial prefrontal cortex of the brain when we're doing this mindfulness stuff, this grounding, this centering, this self-compassion, this kind of cognitive diffusion, and all of these core mindfulness processes. We're coming back to this medial prefrontal cortex of the brain.
What should you do if a patient exhibits and vocalizes frustration or confusion in your office, in the exam room, or at any point during any encounter? Firstly, you should stop what you're doing. Do not take what the patient is doing personally. This is harder than it seems. You need to center yourself and be mindful of your breathing and your bodily reactions. Think, how would you want to be treated or addressed at this moment? Next, you should smile because you are there to help. Speak in a calm, caring manner. Avoid sudden movements in front of the patient. Reassure the patient that they are safe. Remind the patient where they are. Explain to the patient what you are doing and why, and remind the patient that you and the patient are teammates. The healthcare professional needs to be part of the solution and not the problem. If you don't check your actions in a volatile patient situation, you do become part of the problem. You can offer a distressed patient a cold bottle of water, a cold washcloth. You can consider changing the patient environment, moving them to a different room. Give the patient as much choice and control as possible. Ask the patient if they have anybody in the lobby or in the parking lot outside that they can bring in for support who could be helpful in calming the patient. Patients with high ACE scores stuck in survival brain mode may have a harder time learning and focusing. This can translate in the classroom as a child, or it can translate in the exam room with your adult patients.
Hey, welcome back. Today, I really wanted to think about what's the best way to teach teachers about trauma without getting them distracted with all the technical stuff, and what's the most important thing for them to understand and learn. And I thought that the best way to do it might be to just make a difference between a learning brain versus a brain in survival mode. So we'll just call it learning brain versus survival brain. And this is the difference. So learning brain is this brain that's open to learning new information, and it's completely okay with ambiguity and grays and vagueness, and it sees the big picture. It like pulls back and is on the balcony, can look over the forest and figure out what's going on. On an emotional level, people in learning brain feel calm, peaceful, maybe a little excited about what they're about to learn, maybe a little playful and having fun too, and definitely curious. And they're not afraid of making mistakes because it's just part of the learning process. And so they're not really thinking about themselves. And they actually feel a little bit of confidence that if they just apply themselves, they might pick up what they're trying to learn. Now, survival brain, on the other hand, is completely different. It's hyper-focused on threat. It doesn't like ambiguity. It wants clear, hard facts. It thinks in black and white terms. It doesn't want anything to be gray at all. And then emotionally, you can imagine that survival brain makes people feel panicky, feel like a little obsessive and afraid of getting things wrong. And they don't feel calm and open to learning new things. They just want to get things over with. And people in survival brain also really don't like making mistakes, and they are afraid of looking stupid too. So students in survival brain don't want to be picked on. They don't want to raise their hand and ask questions and look stupid. And so these people are also filled with doubt about their own ability to learn stuff, and they're afraid that other people can see how stupid they really are. Now, it's really important to understand how learning brain and survival brain interact, because survival brain always trumps learning brain. And it makes sense because survival brain is just trying to save your life. And so if it thinks that there's something dangerous happening, you better pay attention to it, right? But the tricky thing is that as survival brain stays on longer and longer, it's harder to get out of that. and it's harder to really go into a learning brain. And the way I think about it is kind of like the myth of Sisyphus. You know, that guy who has to push a rock up a hill, and then every day it falls back down and he has to do it over and over again. Well, being in learning brain is like being up on the high parts of that mountain. You can see but it also takes a lot of work to be up there. And at any second, if you're not paying attention and putting effort into it, it's so easy to slip back into survival brain again. And that rock that Sisyphus is trying to push up, well, that's kind of like stress. And the more stressed you feel, the heavier and bigger that rock gets, and it just pushes you back into survival brain quicker. Now, the kicker is that for traumatized people, stress is a really rigid and intense thing. And so with trauma, any little stress makes that rock grow way bigger than it normally would. And because people with trauma misperceive ambiguous situations as threatening and stressful, that rock just stays big all the time. Now, the good news is that the more you control stress, well, the easier it is to be in learning brain, right? Because that rock is a lot smaller. And what I really want to highlight for teachers is that the best way to keep students in learning brain goes back to why I spent so much time talking about attachment. Students best learn when they feel like they're safe and supported by the adults around them. So it's kind of like a baby elephant. You know how like on those nature shows, the baby elephant is like playing with leaves or exploring a tree or something like that and having a lot of fun. And the only reason why they can do that is because there's a whole group of mama elephants around that baby protecting it and looking out for danger. So a kid with trauma or who's stuck in survival brain, it's kind of like that baby elephant who doesn't have protective adults around them. They can't play and learn because they're way too focused looking out for threat and danger. So this is why I really believe that the most important thing that schools need to focus on, way more important than any kind of techniques or curricula, is really whether or not they are creating that environment where students feel like they're surrounded by these big mama elephants who are going to protect them and watch out for them and make them safe. And when students have that, I bet you it unlocks their curiosity, their eagerness to learn, and play as a way to learn. So I hope that's helpful. Let me know if you have any questions in the comments below. Thanks.
Again, just to remind you and to drive home, these are the 5 pillars of trauma-informed care that you want your recipient of your trauma-informed care, either patient or colleague, to feel after every interaction with you. Obviously, as human beings, we will fall short from time to time, but if we do not actively strive to hit all 5 markers each and every day, every moment of every day, we will never, ever succeed. These 5 pillars of trauma-informed care are not an option. They are not a lofty ideal. They are integral to the concept of do no harm in medicine, because if we are not eliciting these 5 emotions, but in fact eliciting the opposite of these 5 emotions, we are actively re-traumatizing and triggering already vulnerable patient populations and colleagues. And this literal abuse contributes to the ill health of America. Patients with high ACE scores often become our healthcare system frequent utilizers and super utilizers. We're going to see in this video one way in which patients with high ACE scores become emergency department frequent utilizers and super utilizers.
Back in the 1990s, researchers at Kaiser Permanente, an integrated healthcare system in California, launched a research project called the Adverse Childhood Experiences Study. They surveyed 17,000 middle-class patients on their exposure to trauma in early childhood and then examined their healthcare records. And when they did this, they uncovered an important correlation. It turns out that children who are exposed to trauma, abuse, neglect, and family dysfunction often go on to become frequent utilizers, even super utilizers of the healthcare system as adults. But why? Well, perhaps, and not surprisingly, it has a lot to do with learned behaviors. Exposure to extreme stress changes the brain pathways of children and sets them up for a lifetime of impaired social and emotional behavior. In short, unhealthy childhood habits become unhealthy lifelong habits. So how does this connect to healthcare? As some experts believe, when a child does grow up in a traumatic or neglectful setting, they often end up in the emergency room for a lot of minor ailments, ear infections, head colds, and other injuries. Ironically, it's also this very trip, the trip to the emergency room, that actually provides a sense of stability. At the ER, adults dress the same, talk the same, and they're kind to children. The kids see it as a safe place, a place they can return to. Unfortunately, as the patient grows older, decades of stress and bad habits increase the likelihood of chronic illness, and a pattern emerges. These same patients begin returning to their place of safety, and as a result, some go on to become healthcare super utilizers, going to the hospital and emergency room hundreds of times per year. These patients will also often introduce conflict with their healthcare providers, once again because of these patterns. After all, conflict is what they know, so conflict is what they create. This behavior then inevitably leads to failing treatment plans, ill health, and tragically, more trips to the doctor. And round we go. So here's the bottom line. When a patient displays troubled behaviors, caregivers may only be seeing the tip of the proverbial iceberg. And if the system doesn't find a way to address all this stuff under here, we're probably not going to see any improvements up here. That's why leaders in the field of trauma-informed care are proposing a paradigm shift. Instead of asking, "What's the matter with you?" let's start asking, "What happened to you?" Considering what we now know, it may be the most effective starting point. And ultimately, that's what we all want, a healthcare system that produces better results, lower costs, and makes all of us as a community healthier and safer. And it all starts with asking the right questions. To learn more, go to camdenhealth.org.
So how can we further help our patients who have elevated ACE scores? ACE is Aware is an initiative of the California Surgeon General Office. We already saw a TED Talk from the current California Surgeon General, Dr. Nadine Burke-Harris. Here is a suggested screening clinical workflow for ACEs for adult patients. Take some time to review this slide. How do doctors and advanced practice providers screen adult patients for adverse childhood experiences? ACE is Aware has, for free, on their website in multiple languages, the De-Identified Adult ACE Questionnaire. It's called de-identified because the patient does not have to check any boxes or fill in any blanks regarding which types, if any, of these 10 types of trauma they have experienced. Because, in fact, it's not important for purposes of ACE screening, and unnecessarily sharing sensitive information with one's doctor when it will not change treatment plans is never anything that we want to happen. Obviously, if patients are enrolled in counseling and other trauma-specific services, they can share details of their trauma at that time. But for an office screen, especially in a primary care setting, it's more important to know the total ACE score of a patient. When you, as a provider, give the De-Identified Adult ACE Questionnaire to an adult patient, you need to tell them that it's not important that I know which questions you respond yes to. You can add those up in your mind by yourself. And however many yes responses you have, that is your final ACE score. You can put your total ACE score in the box at the bottom of the page. And again, rest assured, I do not need to know which specific questions you responded yes to at this time, unless you want to share them with me. Adverse childhood experiences and toxic stress risk assessment have their own algorithm. So as you can see on this slide, those who have a low ACE score, those are scores of 0, 1, 2, and up to 3 without associated health conditions, should be provided education about ACEs and toxic stress and resilience by their providers. They should also be assessed for protective factors, the good things in their life that they need more of, that we could all use more of. Patients who are intermediate risk, these are patients with ACE scores of 1, 2, or 3 who have associated health conditions, need to be provided education about toxic stress, its likely role in the patient's health condition or conditions, and resilience. The patient should be assessed for protective factors, and a joint discussion between the provider and the patient should occur to formulate a treatment plan. The medical provider should link the patient to trauma-informed support services and treatment as appropriate. These services should have resilience building as one of their key components. Patients who are highest risk have an ACE score of 4 or more with or without associated health conditions. They too need to be educated about the role of toxic stress on the body, adverse childhood experiences, and resilience. Protective factors should, again, be assessed, and a provider-patient jointly formulated treatment plan should be devised. These patients should also be linked to trauma-informed support services that focus on building resilience and other medical and/or psychiatric treatments as appropriate. Patients with elevated ACE scores do not necessarily meet current DSM criteria for mental health disorders, and that must be understood. As part of our trauma-informed care pilot at Ascension Health Binghamton, we partnered with the Lourdes recipients of the Mother Cabrini Grant. And as an example, it was a program that was specifically designed for patients with ACE scores. Any program designed for patients with ACE scores can include low cost or free one-on-one health coaching, culinary medicine cooking classes, parenting classes, resilience building training, including but not limited to drum circles and other music therapy, trauma-informed counseling, which can differ from standard mental health counseling or outpatient collaborative care services that a nurse navigator might refer a patient to in an ordinary primary care office. A program specifically designed for patients with ACE scores can also include peer services and standard material resources like transportation, help with housing, etc. Any patient screening programs for ACEs should also ensure that sufficient evidence-based treatment resources are available to handle likely referrals before they start screening patients for ACEs. In the pediatric setting, ACEs can also be screened. Here is a suggested clinical workflow from ACEs Aware, again, an initiative of the Office of the California Surgeon General. In the pediatric setting, the ACE questionnaire is slightly different. The pediatric setting requires a questionnaire also available on the ACEs Aware website called PEARLS. The PEARL screener comes, like the adult questionnaire, de-identified because the total ACE score is what is important to know at the screening juncture, not necessarily what particular types of trauma the patient went through. Here is an adverse childhood experiences and toxic stress risk assessment algorithm for the pediatric setting. Please study this slide. The American Heart Association recommends that universal adverse childhood experiences screening be part of a continuing screening process in a patient's life, both during development, before age 18, and as an adult for those adults whose adverse childhood experiences went unnoticed by their medical providers before age 18. Let's briefly recap what is resilience, the reversal agent of the ill effects of ACEs.
Why do some people do well despite serious hardships? The science of resilience can help us find answers.
We define resilience as a good outcome in the face of adversity. The extent to which we can build capacities in all children early in their lives to be able to deal with whatever bumps in the road or major obstacles may be coming down the track. That's an investment in building strong human capital and healthy, productive adults.
Some children face more obstacles and adversity than others.
It's like having a parent with a major mental illness, growing up in a very socioeconomically disadvantaged community, going to schools that are not good, being exposed to violence in the neighborhood or in the home.
But some children do well despite these significant obstacles.
Resilience is that ability or set of capacities for positive adaptation, allowing you to keep in balance.
We're talking about the kinds of capacities and skills and the abilities that give people a sense of mastery and management of difficulty.
It's tempting to think about children as either having this resilient quality or not. But resilience is built over time, just as and in parallel with how the architecture of the brain is built over time.
It's not just in the person. It's in the interaction between the person and the environment.
So we care about resilience for the same reason that we care about promoting healthy development, because in many respects it is the same. We are interested in promoting resilience in children so that, despite the odds, more and more children can grow up to be productive citizens.
Resilience is strengthened in both traumatized children and adults with ACE scores from the support of other empathetic and resilient adults in the community. Resilience is the antidote, and empathy is the vehicle which allows those with the skills of the antidote to connect to those with ACE scores, and that is trauma-informed care. Let's watch a brief video about how resilience is built. And please note that this is the same way that resilience is built both in childhood and in adulthood.
Resilience is not some magical quality. It's something that really can be built, even in difficult circumstances.
The key active core ingredient to building resilience are the relationships the kids have to others who care about them.
Of course, families play a very important role, but nobody raises children in isolation. We have a huge amount of research to show the powerful impacts of teachers, coaches, other adults in the community with whom children have a chance to develop relationships, who play that critical supportive role of building resilience. As a result of responsive interaction, children build simple skills of coping and adapting. How to stop crying, how to regulate your behavior, being able to defer gratification.
You have an adaptive toolkit that allows you at moments of stress or challenge to bring out a number of potential skills that allow you to get through it.
As children get older, the sophistication of those skills increases. Being able to monitor situations, solve problems. The way we as a society can nurture the development of resilience is to help communities to pay more attention to building the capabilities of the adults who care for children and provide the supports they need to tip the scales toward more positive life outcomes.
And then when communities say, we want to be an active part of crafting the solution, to really understand what's necessary to produce the resilience, that's when the ball gets rolling.
Resilience building, capacity building, is really in everyone's interest, and everyone reaps the benefits when we do that well.